Hello, this is part 3 of chapter 6, Lifting and Moving, and talk about some patient carrying devices. We'll start off with the wheeled ambulance stretcher, also known as the stretcher or the cot. It's commonly referred to as a stretcher or cot. And these are two examples of Stryker brand types of stretchers. And these are commonly found on most ambulances in the Metroplex. On the right side, you see the battery powered assisted lifting cot, which is most prevalent around the fire service, where the cot on the left is manual to pick it up, lift it up and down. The key is you really need to learn how to use the manual stretcher in case the battery goes out on the right side stretcher. It'd be kind of embarrassing that you don't know how to lift the stretcher up to get back into the ambulance after you've left your patient at the hospital, and you don't have a spare battery with you, and you can't figure out how to lift that cot back up in the ambulance, and now you got to call on the radio and embarrass yourself that you need help. The advantage to the battery operated controlled cot, it's easier to raise and lower the undercarriage. The disadvantage of the battery operated cot is it adds more weight to the cot itself or stretcher. It's suggested that the safest level moving of a patient is leaving the stretcher in the lowest position and closest to the ground. That's not comfortable because then we have to be leaning over in order to move the cot. So we usually take it up to about waist height, and between yourself and your partner, both of you keep hands on the cot when you're moving the cot. Remember, it's easier to pull than it is to push, or it's easier push than pull. One of the things about leaving the stretcher in a raised position, it does leave the stretcher vulnerable to tipping over if the patient decides to move, maybe if you're on uneven ground. So the best thing to do is, if you need to move a patient on a stretcher across rough terrain, is to have four-person. Remember, think back to the diamond carry. Loading the stretcher into the ambulance, you need to ensure that the frame is held firmly between two hands and have a rescuer on either side, if at all possible, to keep it from tipping over. A lot of times it's just you and your partner on the ambulance, so you don't have the advantage of having a couple extra people. But if you do, use the extra help to keep it steady. And the other side of that is, when there's only you and your partner, don't be the hero once you get to the ambulance dock at the hospital and just push open the back doors and start unloading that cot. Wait for your partner to get there so that they're there to help lower the carriage underneath so it doesn't slam down. And in case something breaks, that the hook that stops the cot from coming all the way out doesn't dislodge from where it's bolted down, and then you drop the patient. Because dropping the patient is not a good showing about what you know about handling patients. The patient's family frown on you dropping their family member. The patient frowns on you dropping the patient, as well as all the people that are at the emergency room see you drop the patient. And the whole thing about the patient, if you do drop a patient, you got to get them, pick them up, put them on the cot, and then take them in. But if anything, you will have learned one lesson when you drop a patient, and that is you're only going to drop a patient once. And I can tell you that from experience. Some other items that we use to move patients: stair chairs. We saw the picture of the stair chair that's on the upper right that has the tractor treads on them for moving patients downstairs. The picture on the left, the kind of maroon looking stair chair, is used for moving patients down the stairs. But this is an old school stair chair to where you had to pick up the patient in the stair chair and carry them physically down the stairs. Those wheels didn't roll down the stairs, so you had to physically pick up the patient. Benefits of using stair chairs: excellent for use on stairs, of course. And the thing about stair chairs, need to remember that your entity provides a stair chair on every ambulance. Use it. I know they're bulky, they're heavy, and there's a chair in the kitchen that the patient's sitting on. You very well could carry them down the stairs on that chair. But if you drop the patient on a chair that they own or it breaks, you're going to be in a lot of trouble because you had the equipment to use and you've opted not to use it. So then you're going to get into trouble, and we'll talk more about this on the medical legal lectures, but you're going to get charged with negligence. So you have a stair chair on your ambulance, use it if you have to move somebody downstairs. Stair chair transports patients in a sitting position, reduces the length of the patient and device. In other words, trying to carry them down with a stretcher or carrying them down with a backboard. The stair chair can be maneuvered around corners and narrow spaces, and it has wheels so it can roll over different surfaces. It's extremely beneficial in moving respiratory distress patients because they're in a sitting position. You can put oxygen on them for the entire trip down the stairs. Now, stair chairs should be avoided being used in patients with spinal injuries, as they should be immobilized on a backboard. Here we have some pictures of different colored backboards. They can be called backboards, long spine boards, and we use these to immobilize and move spinal injury patients. They can be used when a patient's lying down or standing. We can put this on them while they're standing up and then lie them down. They're long, flat, made of rigid rectangular material, most often plastic, and it's used to carry and immobilize patients with suspected spinal injuries or other multiple trauma injuries. Here we have a patient that is immobilized to the long spine board. This is also known as being packaged on a spine board, packaged for transport. A C-collar is in place. The orange pads on each side of the patient's head is known as a CID, or a cervical immobilization device. It's the orange thing. And crisscross straps across the shoulders and then across the hips, the knees, and if we have an extra strap, we'll put them on the lowest part of the legs around the ankles. Next device that we have is known as a vest type device, known as a KED. KED is short for the name of it. It's called the Kendrick extrication device, and it's easy to say KED. It's used when a spinal injury patient needs to be moved from a sitting position to a supine position on a backboard. Um, the bad thing about the KED device is that it does take a few minutes to put it on the patient, and it also creates some movement of the patient when we're putting it on. This is an example of what your patient should look like when properly secured to the KED. Note that the C-collar and chin straps um, are basically color-coded. C-collar white, head straps white. Then we have colored chest straps, green, yellow, red, and white or black leg straps. So we know which one goes where. Another device that we have is a scoop or orthopedic stretcher. We use this stretcher because it splits in two pieces uh, vertically and allows the patient to be scooped up by pushing the two halves together under the patient. This particular scoop stretcher does not support the spine and should not be used with patients with suspected spine injury. This is most commonly used on athletic injuries. We also have rigid basket stretchers known as Stokes baskets. It can be used to transport a spinal injury patient after we've put them on a backboard. Then we can put the backboard inside the Stokes basket. A lot of times we use it for inaccessible areas by vehicle, water rescues, technical rope rescues. Um, we don't carry these on the ambulance. It's usually carried on the rescue truck, and then we put the patient in there. Here we have what is called a sked. It's similar to a Stokes basket, but it is collapsible and is rolled up and placed in a bag. It can be used for high angle rescue, low angle rescue, and more easily carried because it's in a rolled up pack that you can actually has shoulder straps in case you have to hike into where you're going. It's in a rolled bag, so it's excellent for storage and carrying. This KED we can tighten up by pulling the straps that will conform around the patient's sides. This is very good for confined spaces if you have to get somebody out of a confined space. It's uncomfortable, but it provides good support and immobilization if used correctly. One of the items that is come on the market over the last probably 10 years is called a man sack. You can call it a woman sack if you're using it on a woman. You can call it a man sack if it's a man. This particular one's brand name is Man Sack. What this is used for, it's a canvas type tarp with handles that you can maneuver the patient onto and around tight hallways from a bedroom to the stretcher. And it is also used for moving the morbidly obese, the man sack. But be careful, when you're asking your partner to get something or the engine crew and go, hey, bring me that big old man sack. Don't do that. Just say, can you get us the sack or the man sack, or uh, get us our lifting item that we need. Think about your patient's feelings, especially if they're the morbidly obese. We have vacuum mattresses where air is withdrawn using a hand pump. The mattress becomes rigid and conforms to the patient, and it pads all the voids automatically. This is very essential or beneficial, not necessarily essential, but beneficial in elderly patients who are prone to having bed sores and ulcers or kyphosis or spondylosis, because it will conform to their shape of their body. So choosing a carrying device, look at the patient's position. Do you suspect any spinal cord injury? And if spinal immobilization is mandatory for any patient who has any possibility of a spinal injury, make sure you put them on a backboard. We're not using backboards as often as we used to, and now it's based on protocol. Talk a little bit about patient positioning. Remember our recovery position, the position of comfort, Fowler's, semi-Fowler's, and Trendelenburg. Here we have the unconscious patient without spinal injury in a recovery position. Keep the patient on their side to protect their airway in case of vomiting. We don't want them to aspirate any vomit. That's why we put them on their side and not on their back. Remember our position of comfort, also known as the Fowler's position or semi-Fowler's. Easiest way is if your patient's awake, alert, conscious, and able to talk, you're going to bring the head up before you even put them on the cot, if there's no spinal injury, and then we're going to raise their head up and let them tell you where their position of comfort is. And then we have our Trendelenburg position, also known as shock position. This is used with the patient that does not have spinal injury based on your protocol. We're not going to elevate the legs any higher than about 6 to 12 inches. We use this on the simple syncopal episode, the simple feigning episode of grandma or grandpa on the couch. And of course, with any of these items that we use with patients and it touches patient's skin, and we use them on more than one patient, we need to decontaminate this equipment after every use. And it's for your safety, safety of the crew, safety of the patient, and to prevent the spread of diseases, especially with what we're going through now with COVID. We wipe down everything. And if you think it's clean and you wiped it, the only way you know what's clean is if you wipe it down. Don't take other people's word that they already wiped it down. If you think it needs to be wiped down at this time with COVID, wipe it down. And that's all, folks.